Okay, good morning, dear PT and OT students. It's nice to see you all early in the morning and on this discussion forum. And welcome to our e-learning discussion forum, which is the first time to support your learning. And we're very happy that we have invited all the teachers involved in this topic, the spine related topic in PT and OT, to support you during your revision period of time. And we're very happy that we have invited external guest speaker who is a professional radiologist, a medical doctor from a medical perspective to help you to understand about the imaging, including the X-ray, MRI, and CT scan interpretation. Now, first of all, let me introduce that we're very happy to have Dr. Guo Xia, who is the Associate Professor of the Rehabilitation Science and the subject leader for orthopedic and traumatology subject for the PT. And we're very happy to have Dr. Sam Chen, who is the subject leader and assistant professor in the OT department and the subject leader in the orthopedic subject for the OT students. And myself is Angus, and I think some of you have met me before, the PT students. And very happy to have Dr. Andrew White, who is the radiologist and a medical doctor, and will come to share his professional experience and knowledge to all of you and to answer your questions in relation to how to interpret radio imaging so as to facilitate you to understand what we have covered about the pathology and also about the diagnostic imaging issues. And you're welcome to ask questions in those aspects, and Dr. White will answer you. And so now I think it's time to, due to some technical problem just now, we have a bit delay, and I'm very sorry for that. Now it's time for you to ask the questions for your revision, and we welcome students from PT and OT Science to ask the question. So anyone would like to ask some questions first? If Sam would have anything would like to start off with the OT student, because OT is going to have the final exam quite soon.
Yeah, I think it's good to, first of all, I think it's good to see the PT students, because we haven't met formally, but I'm sure we're going to meet next semester in other courses. And for the OT, I think, I hope that even though it's not compulsory for all of you to attend, I already received a number of requests that were how this has been arranged, so I hope that you can actually ask the question in this forum. Especially this forum is mainly for the spine question, and hopefully you start with some spine related question that related to the RS24X0 first. Yeah.
So I've got a question from the OT student who cannot attend this forum due to the question on the other subject. So it's related to roughly is about the stage, the pathogenesis of the ankylosing spondylosis. Now I don't know how much that the OT student understand about what we call AS in your subject so far, but we can take it as a kind of learning. Now this question, to be honest, is quite factual for the information, but let me interpret in this way so as to help you to understand some background. Now, in the lecture, we have covered about the basic pathogenesis of the SPA spondyloarthritis. In particular, we pick ankylosing spondylosis as the key to discuss about SPA, and cause this mainly affecting our spine. So for this topic, now what his question or her question is about the T-cell promote bone remodeling. Now, if you just pick this, will be a bit confusing. So the whole thing is what I have covered in the lecture note is just telling you the T cell. You can see that the T cell within the emphysis, and that's exactly what we have covered in the lecture. That is the region between the tendino-osteal junction have got inflamed. And in that case, with the accumulation of the inflammation fluid and also the edema, and that will irritate the soft tissue, and we have the chronic inflammation and the swelling, and the soft tissue will be hardened and then will be more weak, and then those things that happen. Now, the question is, these activate T cell could promote the local inflammation and bone remodeling. So maybe the student just cut something so it's not clear in the question, but you can see on the lecture notes is saying that these activated T cell will promote the whole information process happen over the tendinous junction, and that's exactly the key area for the emphasis in SPA, particularly like in AS. And you find that this kind of thing will this kind of the T cell activities will also promote bone remodeling over there. So with the information and the bone remodeling, and then you will have calcified soft tissue around there, and these are just the chemical reaction. For your learning purpose, because you just need to know the pathogenesis, the basic mechanism of these have just recently been recovered in the recent years to know about the mechanism. So I do not need you, for the exam purpose, I don't need you to drill into very detail about the pathogenesis, because you can see this is a paper that I find for you talking about this mechanism. It's just published 2012. So is just recently known a bit more about the emphasis that happen over the tendinous junction for the people with AS. So and we know that is quite related to the activated T cell activities which affect the soft tissue remodeling and the bone remodeling process, and that comes together with the repeated local inflammation. I think that's quite enough for your study at this stage so far. And if you want to know about the pathway that happened, you can refer to the slide 62, which is about the pathogenesis in PT. It's about the pathogenesis of SPA, which I have covered in the lecture. Then you can go through a little bit more so as to know about how the pathway that happen when the T cells being activated and causing the subsequent inflammation happen over the tendinous junction. I think that the slide is more important for you to understand the mechanism, and don't worry too much about it. Yeah.
Yeah, I do have one response to this. Even though in the OT groups we did not have the time to cover such a detail, but we did cover the content on the AS as well. But again, for the OT side, of course, we did not talk about the mechanism or the cellular changes behind the AS or the related rheumatic changes. But it's actually worthwhile to other than looking at the cellular level, what you need to focus is the signs, symptoms, so particularly related to AS, and how that is related to other type of the rheumatic condition. For example, the rheumatoid arthritis or the SLE, for examples. And worthwhile is to compare the etiology of the AS in relation to another topic we actually mentioned a bit earlier, the osteoarthritis, the OA changes, how the progress actually changes in relation to the signs, symptoms, and also the anatomical structure. Those are the ones that you need to particularly prepare for the final test.
I think it's pretty similar to the PT student
Right.
as well, because as I mentioned in the lecture, that is just to let you know about what's actually happening behind, but it's more important you understand about the clinical features, the signs and symptoms, because for your later part of your study in MSK 3, then you will need to know about how to assess a spine with the physical assessment. And by then, you need to be able to recognize the basic clinical features, including the signs, symptoms, and the clinical presentation, which are more directly relevant to your later part of your study in PT. So the pathogenesis is something that back you up in case you would like to read further literature in relation to this pathology. Maybe I take this chance because it's very great that we have Sienna with us today, and you PT students, I know that you have just finished the lecture about pediatric spine, which is quite interesting. I'm always interested in pediatric spine because it's something a very special period So, is there any question to Sienna at this stage?
Perhaps also about this question, the T cells promote bone remodeling. I think AS is also a type of chronic inflammation.
Yeah.
And activation of T cells actually presenting almost all chronic inflammation. It's not. It's actually this is just a pathology in general. Inflammation. It's not specific for AS, right?
Yeah, sure. But they just find it also happen over in AS. So it's a kind of basic pathology. Yeah, is it correct? Yeah. So don't worry too much. It's just common for information. For those of the PD students, refer back to, I think it's covered in the information lecture, right? T cell activation, something.
Yes.
I remember that.
Yes.
So go back to your previous lecture.
In the lecture 2, inflammation, we have discussed what is the difference between, in the pathology, between acute inflammation and chronic inflammation. So the different cell types participate in the inflammation.
Yeah, so don't forget what you have learned.
Looking at the bigger picture first, right?
Yes. Well, there's another question written to us. It's about to clarify, does emphasis of spine mean the junction between the vertebra and the IV disc only? Well, in this case, I think you need to go back to lecture notes that I have a slide telling you is exactly about the local inflammation between the tendon and the bone junction, what we call the tendino-osteo junction. So it's again, it's not just over the spine. As you know, it's a kind of chronic inflammation problem for AS, and with multiple areas being affected. And you can see from the slide I have shown you the picture about the inflammation over the Achilles tendon to the calcaneus. And that is also a very typical example telling you that what does it mean by emphasis is talking about the local chronic repeated inflammation over the osteotendinal junction with the engagement with the activity from the activated T cells. Yeah, so you just know this basic pathology is okay. It's related to inflammation. What are the common cause of autolysis? Oh, let's see, and I have to answer that. What are the common cause of autolysis of the? I think it's talking about the nucleus pulpus.
Well, it's about the intervertebral disc.
Yeah, I think so. Common cause.
It's your part.
Okay, let me find it out. They have really done a very good revision, so they find out all little points from different notes. Now, see which lecture notes they're talking about. Is actually about a degenerative changes over the nucleus pulpuses, and is actually comes together with aging, and also the water contact inside will be reduced with the reduction of the production of the protoglycans, and which is a very common phenomenon about the degenerative change of the PI, the intervertebral disc, and that also affect the elasticity of the intervertebral disc, and therefore is relatively easy to have PID that happen because the elasticity reduce while you still keep being active, as I mentioned. If the PTC remember in the lecture, I said that it's easier for me to have PID than you, because my IVDs have been degenerated already, but I'm still dehydrated already, and I have chronic low back pain, and at the same time, I'm still not retired. I'm still active. So if you remember the lectures, I say that my disc is not as elastic as yours. Well, I'm still moving around. I'm still working, so it's easy to come out, but it's not easy to go back. So sometimes it's because of the loss of this protoglycan and the water content reduced, and IVDs is less flexible and it's easier for you to have PID that happen. And this is the basic predisposing factor that for the PID might happen.
Mm.
We'll see. Maybe Dr. Wang has got any supplementary answer for this medical related question as well.
I think I should mainly comment on the radiology aspect.
No problem.
For the dehydration of the disc, probably you cannot see in the radiograph. That means in case of early dehydration, you can't see anything on the radiograph because the disc itself, the nucleus pulposus, or the annulus fibrosus, they are all radiolucent. That means they are invisible on the radiograph, so you can't see that. And when the disc itself is dehydrated, normally the disc will have its thickness, right? In case of dehydration or long-term or chronic dehydration, the disc will be collapsed and the disc space will be reduced. And then you have a secondary evidence to guess whether there is any dehydration or not. But this is not a must, because if the disc got an annulus fibrosus tear and the nucleus pulposus being expelled out, the disc will also got reduction in disc height, and that will also cause the narrowing of the disc space. And that's why on radiograph you can only guess, but you really don't know whether there is any dehydration in the disc. The only imaging method to confirm whether there is any dehydration in the intervertebral disc is only by MRI. MRI, we go to the T2 weighted imaging, not to be very specific, make it in a simplified manner, is on MRI, we select the sagittal sequence. That means the sagittal scan that is scanning all the way from the mid-axis and the paramedian pictures. And then you can use the water-sensitive sequences. That means some physics that can image the water. If the water content is reduced, and then you can see darkness or hypo-intensity inside the disc, and that is the confirmation of the disc dehydration in medical terms or in radiology terms.
Yeah, I'm glad Dr. Wei actually mentioned this, because we did mention briefly about the neuroimaging about from the functional MRI tell the reflective dehydration. Could you remind the OT student or the PD student, like when we're looking at the T2 image, what would be the manifestation in the functional MRI? Is it darker, lighter, in terms of
I should say on sagittal images, a normal disc is homogeneously white or hyper intense. If it is heterogeneously mixed with grayish signal intensity inside the disc, then it is having dehydration. And when it comes to completely dark, it is purely dehydrated. That means the water content inside is being is gone, actually. And eventually, after complete dehydration, it will have a shrinkage of the disc height and causing reduction in disc height.
So maybe, yeah, other than this one, maybe let's get a time to, I'm pretty interested to understand whether you have any question about pediatric spine, because it's quite hot. We just finished it last week, so
This week.
this week.
week,
Oh yeah, this week. Sorry. Yeah, just on Wednesday. Yeah, sorry.
I'm sure this topic will benefit to the OT's
Do you have
side.
that topic as well?
Exactly what I'm gonna say, because of the too much content in our course, we did not have time to talk about the pediatric spine. So it's actually a good opportunity for the OT side to learn more about the pediatric perspective.
And you have the
our
luxury.
PowerPoint can be shared to no problem.
You have the luxury. You have the expert in pediatric spine,
Exactly.
and Sienna is the expert worldwide in this area. So don't lose this chance. Oh yeah, I've got a question for Sienna.
Oh, good.
Great. Take this good opportunity. Good PT student. Is that open PT OT student? Yeah, good student.
What's the question?
That's how does the vertebral bodies become thicker in childhood and adolescence?
Become thicker
Oh,
in childhood and adolescent.
what does it mean?
Well, thicker means it's an increase it's a diameter increase, or
You talking about getting bigger or?
well, the growth of the vertebral body. There are two directions. One is the longitudinal growth. Each vertebral body has at the upper and the superior, inferior end is covered by growth plate, and the longitudinal growth of vertebral body is through the growth plate, and it becomes thicker is through the intramembranous bone formation, through so the bone formation under the periosteum.
So for this question, for the student, if you are not clear, for all of you as well, if you're not clear, please don't hesitate to ask question because it's directly relevant to your examination and also for your later part of your study. Don't forget that you still need to study the rest of the years. Oh, scoliosis! It's my favorite topic. Please, Sienna. Yeah, it's the expert. Yeah, great PT student. Yeah, Sienna is the scoliosis expert in the world.
Sophia,
Yeah, can you enlarge it? Yeah, enlarge a little bit. Because my
Okay.
eyes getting
What's the
degeneration.
detail of intraspinal abnormality associated with congenital scoliosis? Anterior spinal fusion better than posterior spinal fusion? Well, there are two questions. Intraspinal abnormality associated with congenital scoliosis is quite different, because congenital scoliosis develop in the embryonic stage. During the stage, also, so many other systems in developing, and usually congenital scoliosis, they have a patient with congenital scoliosis may have multiple deformities, like in the spinal cord, maybe also in the cardiopulmonary system and other system. So, Dr. Wai, have you have had any cases congenital scoliosis they associated with intraspinal deformities?
I should say
Example.
intraspinal deformity or intraspinal abnormality is possible, but it is not very common.
Not very.
Usually, the congenital scoliosis has been described by Dr. Guo Xia. For intraspinal abnormalities, no matter it's neoplasm or congenital deformity, that will cause any sort of alignment disorder. And congenital scoliosis is just one of the forms of the alignment disorder caused by these abnormalities, but it is not very common.
Thank you. And anterior spinal fusion and posterior spinal fusion, actually this depends on the deformity. Because the deformity, we have discussed the 4 different types of deformity. The according to the etiology, the segmentation deformity or formation deformity. So it depends on where is the deformity, at which level, thoracic level, lumbar level, and how severe is the deformity. So it's difficult to compare which one is better than another one.
Yeah, I think it's a good question. I'm not sure what's the motivation behind these two questions, but it's somewhat related to the case study I posted on the platform as well. I think I just take this chance to just briefly discuss about the so-called question related to the case study the 15-year-old female with the adolescent scoliosis is exactly the one question is about, according to the cases we posted on the web, exactly because of the orientation of the degeneration and the physician that actually applied on the type of operation that applied to this young lady is actually a PSF around the level of T4 and also the T12. Again, just like what Dr. Guo Xia actually mentioned, the reason is because of the degeneration, particularly problematic in the posterior aspect of this young lady's spine, and that's why the PSF is actually conducted across quite a high, long extension from T4 to T12 as well. And the other thing is the second question about like what's the rationale behind is one could be is about this young lady is still young and this potential for the spine to recover after the surgery. And the other thing is the progressiveness of the condition, because after 1 year time, even though she has been really active as an athlete, the pain is actually become progressive, and something need to be done more invasively in order to correct her spine alignment and also the pain symptoms as well. Okay, so I hope that that this illustration can benefit all of you in terms of the better understanding of the congenital scoliosis.
So, before we go on to this question, is this question from the OT student?
Yeah, it
So
seems
PT.
like because it's a little bit go to the
Frozen shoulder.
the
Oh.
frozen shoulder is a topic not done by me. Let me read it first and then see whether I can respond, and I might need to look at the notes first by Amanda and then a response to that later. Would adhesive capsulitis affect the scapulothoracic rhythm?
Yes.
It would be yes.
Yes.
And any other disease will lead to impairment of the scapulothoracic rhythm. Any comments on here?
I think maybe also is from PT students, well, right?
Exactly, right.
So
I
is-
think the
is-
This has
thoracic,
clinical experience.
because we did not talk about the thoracic.
I have briefly mentioned about the
I think
frozen
it's the
shoulder,
thoracic.
but it's a bit amazing that a student asked about the frozen shoulder in relation to the spinal region, which somehow makes sense with the spine topic. The scapulothoracic rhythm is a good question that, is talking about the movement, the upward and downward movement of the scapula over the thoracic ribcage. And yes, as I mentioned, the capsulitis will affect the GH joint usually, and that affects the joint mobility. Now, in this sense, the scapula cannot move freely on the ribcage, the thoracic ribcage. So the rhythm will be affected for sure, and that's why this will affect the shoulder range of movement. But in relation to the spine, maybe this is more about the shoulder mobility issues and the pathology over the shoulder instead of over the spine. Usually that will also cause some stiffness around the scapulothoracic region, and the thoracic muscle will get the tightness and the weakness. And in this sense, this impairment will affect not just the mobility of the joint, but also because of the weakness of the muscle, and the rhythm will be affected with two factors. So spine itself will sometime being put in a more kyphotic position in this sense. So that might be a cause causing more increase of the kyphosis over the thoracic spine region. But in terms of the rhythm, yes, I can answer you that. is could be due to the capsulitis causing the reduction of the mobility of the GH joint and the mobility of the scapula on top of the thoracic rib cage. What's the questions? Well, still about IVD. Is there any other questions of this?
I think we actually missed one question about the spondylolisthesis.
Ah,
earlier.
yeah.
I think.
Do we need to go back to that?
Okay, hang on.
Like Sam would like to answer something about spondylolisthesis as well.
Yeah, I'm not sure how much detail we talk about for the from the PT side. I think for the OT class, I think spondylolisthesis. I think particularly, I think you should be able to understand that it's be quite prevalent around the lower lumbar region, especially for L4, L5, and also the S1 region. And the reason why is because of the sacrolumbar angle. Especially those actually have a more exaggerated lordotic curve as to start with. And the other one is about the other problem that also related to so-called the overall low back pain. Why the lumbar actually becomes more problematic is because generally the lumbar actually is situated in the bottom of the whole spinal column. And the other thing that particularly related to the spondylolisthesis could be because would also lead to these scoliotic, the sciatica as well. It's because not just someone actually having the spondylolisthesis will lead to a localized pain, but the malalignment of the lumbar L4, L5, and also the sacral region would also impinge the outcoming sciatic nerve, then will lead to the neuropathic condition called the sciatica. So this is something that they, as a whole, I think when you review the topic on the low back pain, I think this is something that you should looking at the spine as a whole, and how this degenerative condition can lead to another neuropathic condition, for example, sciatica.
Yeah. So I guess is it a question from PTOT? From PT student, please refer back to my lecture notes about the cause of the pathology for spondylolisthesis, which is quite clear. So if you remember what I mentioned, the sequence, one thing would be, remember that I've written down different classification. The race Newman, that classification that told you about different types of spondylolisthesis according to the etiology, and those are the causes of the spondylolisthesis. Just please refer back to it. Like I told you that my spondylolisthesis in the lecture, I have got spondylolisthesis here. So my spondylolisthesis is due to degenerative. Yeah, so some could be congenital, some could be due to traumatic reason for the fracture happen over the pes interarticularis, and that will cause the anterior sheath of the vertebral body in relation to the lower level, and the forward shifting of that is the spondylolisthesis that happen at that level. So just go and check about the lecture notes that tell you all different reasons, including traumatic reason, degenerative reasons, or congenital reasons. And here would like to remind all of you that cause Dr. Guo got some urgent stuff, so she will need to leave a bit early this morning, but you're still welcome to ask the question and leave your question in here, and she will respond to you through reply in words, and then you can check the discussion forum in relation to the question. I do encourage you to ask question about the pediatric spine. For OT students, it's good for learning, like Sam has mentioned, it's important for you. I do think that nowadays like OT work quite a lot in pediatric.
As always, we always want to make the pediatric spine as one of the topics, but because we're so packed, right? But the course is not only about the spine, we have to cover some other dysfunction. So it's good that we actually have this forum.
Take this chance, I think, for the OT student, do ask question about the pediatric spine if you find out any. As far as I know now, in the clinical setting outside in hospital or in NGO, quite a lot of OT work for pediatric cases, and you can't avoid to to deal with your patients with different types of pediatric spinal condition. So to train like ADL, right?
Yeah, and
train the
some
ADL
other-
training, you need to know about the spinal condition.
Right. Yeah.
Otherwise, that will be quite limiting for your work.
Yeah, I think pediatric rehab, especially for some of the physical dysfunction kids, I think would be essential because of the opening of the children's hospital in the coming.
Oh yes.
And the other thing is, for those actually who would like to work in the private setting, I think it's a lot of clients would be in the pediatric.
Yeah, so you can't avoid it.
condition,
So
yeah.
do take the opportunity to make use of the forum for your future career.
Yeah.
And for PT student, I'm very sure that you need to face this kind of cases, and I'm very sure that if you want to be exam oriented, we do have questions in pediatrics. But I don't think that it just happened. It just finished 2 days ago, and we won't include a question. No, we have exam question on that. Okay, I know that students would like to concentrate more on exam on recent days, and this is exactly helping you for that. So do ask questions. Now, in here, we got another piece. Read out the question. Why? Why should I read it out? Is the longitudinal growth process in the vertebral body due to the growth plate similar with the endochondral ossification of the epiphyseal plate in long bone? I think this is about the pediatric spine question. And you unfortunately have got Sienna just left. We will send it to her, and then she will reply it on the forum. Please do check it, and then she will reply you about the growth plate issue. It's important, and I do agree with you. This is a good question to ask, because that helps you to understand the prognosis and the disease progression for pediatric spinal condition, and this is important for your diagnosis and your future physical assessment. So we will send it to Sienna, and please check it. And for the rest of you, also check it. It's important. For the next question, Toti College. Well, why don't you ask the pediatric question earlier? Toti College. That's another very important question for Sienna. And sorry, I think I will leave it to her to answer you. As I mentioned to all PT students, you missed the golden chance. She is the well-known expert in PD spine for many years. Published a lot of high-level papers in pediatric spine, and got a lot of award because of that. And so you missed your golden chance to learn from your expert. Okay, I think I will just refer back to her. She's the best person to answer you. Good morning all. I'm curious to know if there are any therapeutic exercise prescribed for patient after post-op. Oh, wow, perhaps in particular after non-fusion. Corrective scoliosis surgery. My dear PT students, thank you for your questions. You're asking something that I need to seek for the help from Sienna. Don't worry about it, Sienna responded quickly. Briefly, from what I know so far, therapeutic exercises. Yes, there are some kinds of therapeutic exercises for scoliosis after operation. For different type of scoliosis surgery that we need to take different consideration in our exercises. We'll say there's no particular therapeutic exercise for post-op scoliosis condition is the best. According to my knowledge, in scoliosis so far, that there are so many studies talking about the use of brace, use of posture adjustment, and exercises to correct the spine, and even to maintain a better position of the spine after the scoliosis surgery. But there's no single therapeutic exercise is the best. So yeah, maybe I will try to let Sienna to answer you in detail about anything that we need to take note on after corrective scoliosis spinal surgery. But which is a very good question. Well, on top of this, maybe we can ask Dr. White, see would you have any particular advice for the students when they need to consider the treatment for people, like exercise or movement for people after scoliosis surgery? Because like from a medical perspective, what we should take care of after scoliosis surgery?
Okay, let's put it into a basic term. If immediately after scoliosis or spine surgery, we have to put the physio or therapeutic exercise into different phases. That means immediate post-op, subacute, or even in a long-term or chronic post-op period. In the early situation, immediately after post-op, patient shouldn't be moving, right? In medical or imaging wise, we have to stabilize the patient and making sure the soft tissue and everything post-operative changes are subsiding. That means the edema, inflammation, hemorrhage, all are subsiding before we start the patient movement. That is the most important thing and the basic principle. The second thing is, it is to strike a balance, because the inflammatory or reactive fluid or post-operative fluid around the operative site, they are all having the cytokines or inflammatory mediators, and all these things will resolve, but eventually they will cause a chronic inflammation and fibrosis. And after resolution of the fluid, the soft tissue will become fibrotic and also cause the stiffness. So we have to strike a balance. Once on one hand or in one arm, the inflammatory fluid or the post-operative fluid or the blood or the hemorrhage is resolving or reabsorbing, and on the other hand, the fibrosis kicks in. So usually the golden period to start the early physio is around 2 weeks. It's around 2 weeks. 10 to 14 days will be the best period to start the physio.
That's a great implication to us. Like I think back to the basic inflammation pathology, that you need to have the acute inflammation subside, and this is a very good basic understanding that you can't re-injure your patient with our assessment or treatment. And I think this quite clear from a medical perspective, that you know that is important for you before you prescribe any exercise. Yeah, don't just guess. Yeah. Rupture of ADS. What's this?
This is OT.
PIP joint.
This is hand surgery. Rupture of the FDS tendon and that of the lateral
Swan
sleeve
deformity.
are the cause. However, this is different from
Is
the
it from OT
side.
Yeah,
It's 2 times.
because I know that I haven't covered that in my
this
lecture.
is,
Well, it's about hand.
It's different for the side. 2
Mm.
type of rupture. Yeah, I think this question is I can't fully understand it, but I think is to for this is a flexor tendon question, is the difference between the Swan neck deformity that was lead to also with the zone 1 injury, and of course that will already lead to the middle finger, right? And then if someone actually have a loosened volar plate actually around the PIP joint, then would also lead to the subsequent Swan deformity. Okay, so don't get confused with the Swan neck deformity when we're talking about the rheumatoid arthritis. And the main difference again is in the context of the tendon injury, the Swan neck deformities is actually an additional problem with the volar plate happening in the PIP joint. That may not be happening to all of the the patients that actually having the flexor tendon in the zone 1 condition. Okay, so this is how I would respond to this question. Okay.
Well, Dr. Wise, a question for you. Although it's related to pediatric spine, and we will also send it to Sienna to give you additional information for your revision purpose. But I think it's quite medically
Yes, good.
related.
Thank you for asking the question. I really don't know whether it is good for your examination or not, but it is good for your practice. If you say in terms of medical imaging, I should say in terms of radiography or radiology or X-ray, the research sign is the iliac crest ossification. Usually we grade into different grading, 1, 2, 3, 4, and then eventually fused 5. And actually the grading is to identify the superior rim or the iliac crest ossification according to your lecture handout or lecture notes or anything. But this is only for radiography. That means if it happens on MRI or on CT or on ultrasound, there is no ultrasound or MRI or CT research sign. There is no. But we can postulate the degree or the rate of ossification and fusion of the epiphyseal plate according to the research sign classification. I think this is a purely an radiography or X-ray term to describe that, because in, I should say, on MR, on ultrasound, on CT, probably we can clearly see the growth plate and also clearly see the ossification and degree of fusion of the growth plates, and that's why we don't need a sign. We can exactly see it and grade it. And also for the triradiate cartilage in the AP view, antero posterior view, it will be difficult, and I think it will be very inaccurate to use the triradiate cartilage in the AP view only to document any possibility of childhood DDH or slip epiphysis of the hip, because we have to know there are several lines. One is the curved Shenton's line, and the two other lines are the Hugrinus line. We have to locate it, and all we need to do is to making sure at the hip joint we make a cross there, and making sure we identify the triradiate cartilage, which is the unfused portion or radiolucent portion of the part of the bones of the acetabular region. And then we have to know exactly the position of the femoral head and neck. If anything that is either dislocated outside and superior or outside and inferior, we are suspecting any kind of DDH or CDH. We call it a congenital dislocated hip or developmental dislocated hip, or any kind of slip epiphysis. That is important. On AP view, you imagine the triradiate cartilage is not in profile. That means if you see my two hands like that, my finger gaps will be in profile. But on AP view, it is slightly oblique, and that's why you can't see my finger gaps clearly. And that's why solely, that means only relying on the AP view to identify the triradiate cartilage, it is not too accurate. And usually nowadays, people will use ultrasound, which is no ionizing radiation, fast and accurate to document and to delineate the triradiate cartilage on a pediatric patient.
I hope this answers your questions about that. I guess when this student asks about the Richter sign, maybe it's related to the diagnosis of the scoliosis. Would you also tell them a little bit more about how to interpret that in relation to the diagnosis for the scoliosis?
We have from radiology point of view, okay, it all depends on the geometry. I should say, let's make things simple. We all depends on the geometry of the pelvis and also in relation to the spine. And in terms of the scoliosis, okay, the geometry involves first whether it's normal geometry, second whether there is any symmetry on both sides or on contralateral side, and a third thing is whether there is any concomitant abnormality in the upper or lower sacral and then lumbar spine. That is all important. In medical terms, or in what we are interested in is, first we have to exclude any primary cause of the scoliosis. That means other kind of pathology other than the spine itself or intraspinal canal pathology, that is already being excluded. And then we'll know whether the cause of the scoliosis is due to congenital, no matter it's partial fusion or failed or partial segmentation. And eventually we'll like to know how severe is the scoliosis before we start any conservative, or if it fails, and then surgical management. That is the overall concept of it. Okay.
Yeah, thanks. I hope this helped you to understand the purpose of identifying the Richter sign. To make a better judgment whether that is a possible progressive scoliosis or is not going to worsen. It's going to be more stable with the assessment of the Richter sign, and we will also get more information for you. I would like to invite you to also ask some more questions. We haven't finished this discussion forum yet, because there's still a lot of questions, I guess. Maybe before you ask the questions, let me start to ask you some questions. I think it's good for revision. I always like it. And then the solicitor will help me to. I know some of you are maybe in a sleepy mode, and now it's time to wake you up. And now, can solicitor help me to pick any student from PT, and also will be from OT. Don't worry about it. And from PT student, I would like you to try to answer me by word in relation to the normal lines, the normal 7 lines that you should able to identify over the lateral cervical spine radiography. Remember that early in your spine 1 lecture, we have talked about that 5 common lines that you should identify at the beginning when you have got the X-ray of the cervical spine, and this is very basic, and I hope to pick this as the starting point to have like Dr. White to further elaborate about how to accurately to assess a spine over the X-ray. So now I just now pick any students and please reply me by word. You can just type it, or if you want to, you can have a live show to answer me. So you just help me to randomly pick one. So the question is the basic assessment of the 5 lines over the lateral cervical spine radiograph and on the X-ray. which are the 5 lines that you should, which are the 7 lines that you should identify? Just type me the 7 lines. Who have we got? Oh yeah, we have got one. Is that the one? Have you picked one? Who is the one that you picked? Yeah, so if you don't have questions to us, then we will have questions to you, because it's time for revision. Kelly Chan, please just type me the 7 lines. You can go back to the lecture notes. Spine 1 for the PT. And after this question, we're going to have another question for the OT students, so please wait. Can you find it out, Kelly? Just in your PowerPoint. Or are you in a sleepy mode? It seems that we don't have any response. Is she typing? Not even typing. Hey, good morning, Kelly. Okay, we keep this question on. Now, is also the question open to the rest of the other class? If any of you would like to answer as a revision, just try to pick that from your lecture notes and type it in here. Cynthia, are they still being connected? So silent. We got some questions just now, and no questions suddenly.
They should be online, right? But not asking questions.
So does it mean that for the PT student you have no question for all the spine lectures? Therefore, you should be okay to answer all our questions in spine in your coming exam, right? So I don't need to worry, right? I will get all A or A plus.
Yeah.
From
Same
you.
thing for the OT as well,
Right? And for the OT student, maybe at this point we're still waiting for Kelly Chan to answer. Yeah, I will chase behind you, so I need to wait for your answers. So anyway, now maybe Sam can ask the questions to the OT
I
student.
think since there's no questions for us, which is surprising because you seems to have a lot of the question when you see me in lectures, but I think it's a good chance to discuss another case study I posted, and since we got Dr. White here, and maybe he can actually give us another more insight from the medical perspective as well, because the case I posted is actually a possible spinal stenosis, and one of the question I posted is because the this client actually, after the is fairly old gentleman, I think would be in his 70s, and what you learn in the class is perform one of the tests called the straight leg raise. And my question posed to you is, even though it's not illustrated clearly in the scenario, my question to all of you is why this client, possibly having spinal stenosis, does not have a very clear sign of the straight leg raise, and what's the reason, and any response to these 5 options. This is actually the question 1 for this scenario. See whether they have any answer for that.
You can just pick any OT student, and so visitor will help us.
I'm not sure how available they are though.
Yeah, just kick them.
I do have the list here, or Sophistia can actually randomly.
The question.
Yeah, you can
Yeah,
you can
yeah.
read it through, please. Yeah, give some comments on here. I just post some
Yeah, it's just
really elementary
Pick
question
any
for
kind
them.
of question. Hey Kelly, I'm still waiting for your answer. And if I haven't got it from you, I will ask you in when I see you next time. I'm pretty sure we'll see you. Okay.
Anyone response to the spinal stenosis question? Or Sophistia actually picked one student, right? What's his name? Hui.
No, just is there any specific question for the OT student? Maybe just shy.
Yeah, the
and
question
she'll pick that
to
for
all
you.
of you is, for someone actually with spinal stenosis, why not a very clear sign of the straight leg raise, neuropathic pain?
Okay, then who
If
you would
not-
like to pick? Who's the lucky student? We're going to have a lucky draw.
Is Cherry?
Is this one? Is
Can
that the
you-
one you picked? Is it okay for you?
Or is,
take this one.
which is the last Sun? Sure.
So the OT, the lucky student from the OT side is
Oh, it's Katie. Is Katie here?
should be here.
Oh, because you're picking the one from online. Okay.
Yeah. So
Okay, Katie. So, any response to the first question of the spinal stenosis? Just try your best to answer one of the 5 options.
spinal stenosis. Or do you need to tell her about the question again?
Yeah, the question is, after you read the scenario I posted for this older gentleman, if I still can recall, yeah, 70-year-old male, and what is the reason why this patient complained the radiating pain at the bilateral buttock pain, but the straight leg raise actually negative. That means when you actually perform what we learned in the tutorial by raise the affected limb in a certain degree, 30 degrees or above, then it's actually not much of the radiating pain, but the pain at the buttocks is actually persistent.
Now, while Katie is it Katie, right?
Katie.
Is answering the question from Sam. If you're not clear, you can ask. Okay. Now we have finally got the answer from Kelly Chan from the PT side. Thank you, Kelly. Yeah. So we have got the answers from you, and I would like to take this great opportunity to ask the expert in radiology to help us to better drill into about interpretation of X-ray based on these basic 7 lines. So would Dr. White help us to accurately find out the lines over the X-ray from your experience,
Okay.
or
Now,
anything we need to know?
could you go to the little software,
Can they see that?
the paintbrush probably?
The paintbrush. Can they see that? No.
Not for the moment. Okay.
You can't try.
Or can you briefly let them know when they find out those lines on the spine X-ray, or any additional information that you wanted to add
No.
technically?
First of all, okay, you have to know that all these lines, don't try to remember it. Try to make things simple. It's like that. All the vertical lines should be in continuous fashion. If any kind of on sagittal view any anterior or posterior disruption of each line, you are suspecting either unilateral facet dislocation or bilateral facet dislocation or fracture. That is more important. If you were to choose the most important line, which line will you choose?
So out of these 7 lines, you mean?
Out of the 7 lines, which line will you choose the most important line? That means this line must be in continuous fashion. It shouldn't be disrupted. It shouldn't be deviated. Which line will you choose?
Or the other student can also answer when you are checking on these 7 lines, because it's quite important. If you remember in the lecture, I told you that you need to be able to read the basic information from the X-ray so as to make a better judgment. Otherwise, you provide a physical assessment, you injure the patient instead of helping the patient. So, or maybe Dr. White can also just tell them the important information about it. So now please go to check about the print brush, the print board.
If I were to choose, can they see the paintbrush now? Okay, this is the spine. Okay, this is the coronal view. I would say this is the coronal view. Okay, making sure you can understand this is the coronal view, and this is a sagittal view. Sorry for my handwriting by the mouse. That is very ugly. Okay, bear me. Okay, and then this is the axial view. I'm going to demonstrate to you. These are the things or the concepts that is important. Now imagine it is the same level. I should say these are the same level. I try to make it more illustrative to you. If I were to choose the most important line, no matter it's on X-ray, on any kind of imaging, X-ray, CT, or whatever, this is the vertebral body, okay, and this will be the disc, okay, and this will be the anterior part of the patient, anterior side. Of course, this will be the posterior of the sagittal region, and this is the imaginary dura and also the imaginary dura, and then in between the dura and the bone, that will be another layer. That is the posterior longitudinal ligament there in between, and this is the anterior longitudinal ligament. If I were to choose, this is the anterior vertebral body line or anterior spinal line, posterior spinal line or posterior vertebral body line, and this line will be the most important for me, because anything of fracture of the vertebral body, that will cause a retropulsion. That means posterior protrusion of the bone. That is retropulsion, and that is important because that will cause a spinal canal stenosis. Any disc deformity causing disc protrusion, that will also cause spinal canal stenosis. That is so important. You have to bear in mind that that is so important. If I wish to complete the story and then I wish to draw in the mid-sagittal region, it's like that. Ignoring the portion of the superior inferior facet or superior inferior facet. That is so important. Making sure the yellow part, the spinal canal, making sure it is very intact, and inside there is no bone on X-ray and no soft tissue or abnormal soft tissue or blood or any kind of mass that is compromising the yellow spinal canal. That is so important. And the second thing is, we have to know any kind of on this coronal image, you can see this is the lumbar spinal nerve root or exit nerve root. Imagine this is L4 and this is L5. So any kind of bone retropulsion like this bit, imagine if there is a retropulsion at this level, this is the pathology and this is the pathology. Okay, that will affect or compress on the L4 and L5 nerve roots. Imagine this is the L4, L5 vertebral body, and this is the intervertebral disc, L4, 5 intervertebral disc, and this will be the L4 exit nerve root, and this will be the L5 exit nerve root. So anything at this region or the bone or the vertebral body causing retropulsion, they will compress on the L4 and L5 and also the rest of the sacral spinal nerves and causing symptoms, no matter it's a sciatica, no matter it's a cauda equina syndrome, disturbance of the sphincter. That is important. And what is more important is here, if you imagine if there is a disc protrusion, I will draw as a blue line, there is a disc protrusion at this region. At this region, this is the posterior right paracentral to the right lateral disc protrusion at the L4-5 intervertebral disc. What would happen is it goes a posterior paracentral disc protrusion. If I draw the disc here, it will be like that. That is the disc at this level, axial level. That will be the disc and causing a protrusion there. This is the protrusion because of the tear at the annulus fibrosis. This is intact, and this is broken annulus fibrosis, causing the expulsion of part of the nucleus pulposus material into this region. And eventually, this is at the L4-5 disc. But the symptom would be because the nerve root is being compressed. I should say here, this is the right-sided nerve root, and this is the normal, not being compressed left-sided nerve root, and that is the dura mater. In fact, this is the compressed L5 nerve root that caused the problem. Compressed L5 nerve root, L5 nerve root that causing the problem. So the dermatome will be L5, and the jerks, reflex, whatever is also L5 nerve root. But the disc is at L4-5 disc level. If you look at on the sagittal image, we go back to this sagittal image, you can look at the L4-5, that is the foramen. The foramen itself could be normal, and this is the exit nerve root at L4-5 level. This is the exit nerve root at L4-5 level, and it is also called the L4 nerve root. It's already being exiting out. That means the L4 nerve root is already out there, and it is L4 nerve root is normal. That means at L4-5 level, if there is a disc protrusion, people will always say, oh, there could be severe, moderate foraminal stenosis and causing L4 nerve root compression. But that must not be the case. And most of the time, most commonly, is causing the posterior paracentral disc protrusion causing compression of the L5 nerve root at the epidural. This is the dura mater at the epidural region, or the lateral recess obliteration, and causing L5 nerve root symptoms as well. And that means L4-5 level disc protrusion, if it is not exactly at the foraminal protrusion, if not exactly here, then it will not cause L4 symptom. It will cause L5 symptom instead. And that's what I have to say.
So for all of you, when you interpret the MRI, check about the IV disc protrusion. Make sure that you check about the direction of the protrusion, and you can diagnose or make a judgment clinically that which level have been affected and what are the expected signs and symptoms from your patients. On your patients during the assessment, it's important to correctly interpret the MRI, the imaging.
Yes. And in terms of your teacher's good illustrative case, this is the dural sac, this is the dural sac, and if you can see it here, and you can imagine here, there will be two more facet joints there. The facet joint, I should make it better. These are the facet joints. Okay, I'm trying to erase that, and I'm drawing you one normal facet joint. This is on the left side of the patient. This is the left, and this is the right. Just like here, this is the left and this is the right. And if you can see it, this is the normal facet joint. If an abnormal facet joint is like that, first, it will have marginal osteophytes. So we'll draw the marginal osteophytes there, osteophytosis there, and this is the facet joint. So I'll rub off all these normal stuffs and draw you the marginal osteophytes. We'll have articular cartilage thinning. So it's a broken bluish articular cartilage. It's thinned or partially eroded. And then we'll have a capsular thickening. Very thickened capsule like that, bulging up because of the osteoarthritis or spondylitis. And then will cause the fluid inside. This is called the facet effusion or the zygapophyseal effusion. And eventually, and also because of all this irritation, it will also cause the ligamentum flavum hypertrophy. Now this is the normal side and also the normal capsule here. Okay, and this is called the hypertrophic facet arthropathy and ligamentum flavum hypertrophy. Because it's hypertrophied, it pushes the dura mater further inward like that. That means this is the normal side, and the abnormal right side will be bulging in like that. This is the dura mater, and causing compromise in the lumen of the spinal canal, eventually causing nerve root compression.
So the nerve compression could be due to the osteoarthritis change.
Osteoarthritis causing capsular hypertrophy and ligamentum flavum hypertrophy and thickening, eventually compromising the dural sac or dural canal and causing reduction in the caliber and cross-sectional area of the spinal canal and eventually causing the nerve root compression.
So is the consequence from the stenosis because of the hypertrophy of the ligamentum flavum?
Yes.
And the canal reduces in size, yes, and that create a compression to the dura.
Exactly.
So I hope this also helped the PT students to go back to revision on the lumbar stenosis that we have mentioned, which is based on, as I mentioned, based on different pathologies, you can have the stenosis over the spine. And this is the illustration to you that is a possible a cause of the stenosis, and then can cause the neurological signs symptoms from the back to your lower limbs. In this case, not just from the IVDs, but from the joint. As I mentioned in class, stenosis is a consequent result from a lot of different reasons, and this illustrates several sources of the reasons causing the stenotic change. Now we have question. Want to ask question case 1 about the spinal stenosis. Pain aggravated by standing and ambulation, but why the physical examination show full LE motor string, lower leg, is it? LE and
lower extremity.
Normal deep
Case 1.
tendon reflex and sensory examination.
Case 1 is not your question, right?
Is it? No problem. We can answer that. So, spinal stenosis. Okay. Now,
It seems like it's the one that I posted, I think.
maybe Sam can help to answer a little bit about it.
Yeah, okay. Yeah, assuming, I'm not sure why it's called case 1, but I think it's the detail, I think is related to the one that I posted. Okay. And first, go back to the original question I posted on the MCQ is why actually straight leg raise is actually negative is exactly what Dr. White actually mentioned. This client main thing is the straight leg raise is related to the peripheral nerve impingement that leads to the radiating pain, and which this client does not have. And if we actually apply straight leg raise on someone actually with spinal stenosis, which is not a peripheral nerve impingement, then we're bound to not to have a positive sign, which is actually the patient would not complain any radiating pain around the buttock area all the way. Could be, depends on the different severity, goes to could be to the back of the calf or even the back of the heel.
Can they see that?
So this is actually assuming this is actually not a peripheral condition. On the other hand, is the question is why this, if it's actually a central problem, then why these patients still have the full muscle string that which related to the myotome intact, and also the deep tendon reflexes. Even though the detail of the cases will not give you the full answer, but this would actually imply the pain originated or complained by the patient. One for sure is related to the caused the discogenic pain caused by the AFIVD. That's one, and so that's why you actually keep complaining the localized pain around the lumbar spine. And also because of the persistent impingement of the disc protrusion, and also the nerve that comes out from the L4 or L5 level, then that's why it actually keep complaining the pain sensation persistently going to the buttock area, and fortunately, because of impingement is actually not so severe to affect the reflexes at the spinal level, and that's why when you test the full strength of the motor level, and also the deep tendon reflexes, and also the cutaneous, which is the dermatome, is actually still intact because the protrusion is actually not severe enough to affect the central reflexes. However, that the pain could be due to the discogenic pain due to the protrusion of the IVD from behind as well. Okay, so this is one of the way to interpret this case. The main thing, especially for the OT side, I think, is to to differentiate which type of pain is actually more central. Particularly the stenosis would be one example, and versus the strict leg raise is particularly would be a good test for the peripheral nerve impingement. Sciatica would be one of the example.
Yeah, so thanks for Sam's illustration. Maybe we can take a look at this model to give you additional information. Now, we know that this is a spinal model, and I particularly make it in a more strict way to make it like a stenosis condition. Now, you can see from the lateral view, the sagittal plane. Now you see that they should, the patient should have the lordosis, but I make it reduce, and this is try to give you the model about a spinal stenosis condition. Normally, we have the lordosis and the spinal canal that wouldn't impinge on the spinal nerve and the spinal cord. Because of the lordosis, you give the space to the nerve and the nerve root. Now, when you have the stenosis happen, relatively the joint close up and the space reduce, and sometimes maybe the height of the disc reduce. That anyway, that cause the final consequence is the reduction of the space over the spinal canal. Now, that makes the condition. You could have the reduction of the space causing the pain over the low back region, what we sometimes call central pain over the spine in our term, and sometimes some people will call it localized pain over the spine because of the compression from the joint. So it's not uncommon to see that a patient telling you that I have pain over the back but no problem over the legs. It doesn't mean that always you have the stenosis, you must impinge to the nerve root. If you have no influence to the nerve root, then the peripheral part of your body wouldn't be affected in this sense. Main part of the body being affected will be about the local region because of osteoarthritis or any degenerative changes or swelling that happen locally. And your sign symptom like pain, stiffness, that will only be localized. Once you have any influence to the spinal nerve root, when the spinal nerve root is being affected, like the strict leg raising and the reflex, that would be quite useful for you to assess the condition. Those are the peripheral issues that happen because the spinal nerve being affected. So it doesn't mean that all patients with spinal stenosis must have peripheral nerve being affected, because it depends on the severity and depends on the part being compressed. If just the joints being compressed and not as severe as causing more compression over the local region, the neural tissues might not be affected. Now in this sense, you might not have any distal sign symptom to the lower part of your body, and the reflex wouldn't have any significant changes, and you might not find any change over the reflex and also over your strict leg raising or the dermatome, myotome. All this depends on whether your nerve, your neural tissues being affected. So spinal stenosis, if the PT students you remember, is just a condition. Anything that reduces the spinal canal space, the diameter of the spinal canal, that could be a kind of the condition for the spinal stenosis, but not necessarily they have the same reason for the reduction of the space. Not necessary that they always will have the problem affecting the nerve. So they can have just localized signs symptoms in this case. Okay, now I would like to take a chance to ask another question to gap the time for your revision. Now, for the PT student, I think would be quite helpful for the OT students as well for learning purpose. I would like to invite Dr. White to further illustrate how to read the X-ray about different kinds of common spinal fracture. Now, in the PT side, in the lecture, I have introduced you some common type of spinal fracture in spine 2. After the whiplash, a whiplash can be a reason causing this kind of spinal fracture, but there are several consequences, including extension injury or flexion injury, and there are different kinds of fracture over the spine, the vertebra. And now we would like to take the opportunity from Dr. White to illustrate you how to correctly interpret different kind of spinal fracture. Particularly, we will first go to talk about flexion fracture and the extension fracture, what we call flexion teardrop fracture and extension teardrop fracture over the vertebra.
Okay, now let's take a look in the little paintbrush software. Can they see that? Okay, that's good. Now you can see this is the sagittal view. No matter it is a lateral X-ray or a sagittal reformated CT or a sagittal scan of the lumbar or of the lumbar or sacral spine. As you can see it here, it is quite similar. No matter it is a lumbar spine concept or from the morphology it is a cervical spine, it is very simple to illustrate that. This is the vertebral body, and we have the anterior side, this is called anterior side, and we have the flexion injury or extension injury. As you can see it here, in flexion injury, the space is being reduced. That means the intervertebral disc space is being reduced at this region. Causing narrowing of the space and then causing widening of the interspinous space as well. And then because the bone here at this anterior-inferior corner and also the anterior-superior corner of the lower one vertebra, no matter it's cervical or any level, they crush into each other, causing a teardrop fracture. Okay, to recite or remember or regurgitate the morphology or the shape of these kind of fracture, it is of useless help, I should say. You have to know the mechanism, and then you can see, because it is crushing between this one, the upper one in this direction, and also the lower one in this direction. Very often you can see there is another crushed fracture at the lower vertebral body anterior-superior corner because they compress into each other. So there is also a crack fracture here, and this one is cracked and displaced. This is the flexion injury. And for the extension injury, you can see it here. The anterior side is being widened and the posterior side is being compressed. So you can see the narrowing of the interspinous space there, and also you can see widening or stretching of the anterior soft tissue. And because all these spinous or vertebral body bone margin, they are connecting to the anterior longitudinal ligament as well as the annulus fibrosus or the outer connective tissue of the disc. The traction or extension of the spine will causing avulsion, that means a passive pull of the anterior-inferior corner. And this kind of pull is not a crushing, and that's why it is of a thinner or taller bone fragment here instead of a crushing fragment. And because to some extent the pull usually more significant at the cranial side. Why? Say for example in the cervical spine, because in the cranial side you have the head up. The head is like that. The head is also called H, is also heavy. That means the momentum is extending backward and causing the pull or the thrust more cranial directed, and then it will cause the more superior vertebral body to have a pull and a bone fragment here. And how about this one? Would that be fragmented? Actually, it is less common. It's all because of the angulation or the posterior flexion or the extension mechanism that will cause the pull, and the pull will be a disruption of the ligament. Sometimes the ligament will be disrupted, and also will cause a linear and more elongated avulsion at the antero-inferior corner of the bone.
So clinically, when they, like in the future when they go to have the placement, how can they distinguish this is a kind of flexion injury or extension injury from the X-ray?
If I were you, I have to bet. The most important thing is here. Look at my colored pen. It's here. If there is concomitant narrowing at the interspinous spaces and also crash or crushed fracture of the spinous processes at multiple levels, that must be an extension injury. In the other way, if there is widening of the interspinous space or spaces, and there is intact spinous processes, and you can see the narrowing of the anterior intervertebral disc spaces at this region, and also crushing of the bones at this region at multiple levels, that must be a flexion injury. Once we decided the flexion or extension injury, and then we will know what type of teardrop fracture. The teardrop itself is just a morphological term. That means they label it because it's like a teardrop, but you have to know and guess the mechanism. That is important.
Thank you very much. It's very clear.
Very helpful.
To have the radiologist to explain that.
Is it okay I ask a further question?
Yeah, sure.
Because for the OT group, we also talk about this mechanism you just explained in relation to different type of the spinal cord injury, right? Because talk about posterior and anterior. Could you elaborate more about the extreme flexion and also extension flexion injury, and how those are related to the anterior and also the posterior cord symptom that we also cover in the OT classes?
Okay.
Yeah, which type would be more related to the anterior type, which seems to be more prevalent in the clinical setting?
Okay.
Yeah. Can you elaborate on that?
Okay. What you're asking is which type of or how the mechanism using the pictorial diagram to explain the anterior and posterior cord symptoms or syndromes. Now, that is also a very, very, very interesting question. I can use a more interactive approach to you, because I really don't know what you've been taught to the student, but it's all right. It's the concept is very simple. In these two radiographs or imaging or CT or MRI, we omitted one important thing. It's the spinal cord here. This is the spinal cord. If it is at the level of cervical, thoracic, or lumbar till L1 or L2 level, depends on the ending of the conus medullaris, right? Okay. Can I ask or consult you guys one question? In the spinal injury, what physical examination will you do to confirm whether there is any anterior or posterior injury? Physical examination.
Right,
Okay. How do you move the legs, arms? How do you test the sensory motor? Because I really wish to know what levels of things you know, then and then I'll input.
Yeah, for the posterior and anterior, it's not mainly about the motor, but also actually what I actually talk about in the OT class is actually the two categories of the sensation that related to either the anterior or posterior cord. And what they learned so far is if someone actually have a more anterior injury, then they will have a more problem with the pain and also the temperature sensation impairment, and they would tend to have more intake, proprioception, and also some other light touch sensation. This is what they learned so far. And what we did not have time to talk about is, since you're talking about the mechanism, what type of the extreme flexion or extension would lead to the anterior cord syndrome. Yeah.
Okay. Now let me do it to you.
Okay.
That is quite interesting.
Mm.
You know what? Now this is the extreme flexion, as you can see it here. I'm going to write you the intervertebral disc here. Okay. My drawing is not very good. Okay,
No,
that's
you do
why
very well.
I'm not a painter.
No, you do
Okay.
very well.
You can see, whenever there is a flexion injury,
Mm.
okay, the anterior pressure will be high, right? And the posterior pressure will be lower
Mm.
because it's a distraction,
Right.
right? So, where will be the disc protruding? The disc will be protruding this way.
From it,
And then for the soft tissue, it will cause direct impingement into the spinal cord. So the anterior cord will be more affected, correct?
Right.
In other sense, if for extension injury, that will be the anterior part will be more distracted. And then the posterior spinal line or the posterior vertebral body line will be compressed. So the opening will be sealed off. In case of the disc, okay, it will be prevented to protrude out because the bony gap is narrowed. And that's why the anterior part is less significantly affected. But in other senses, because the posterior part also we have the ligamentum flavum and the posterior soft tissue structures that will be protruding anteriorly, and then that will cause the posterior cord injury.
Posterior.
Now this is the simple term, this is a simple mechanism, but in fact in real life it is not completely the case. Why? Because there will be another issue. This is called only the mechanical mechanism or the mechanical terms that causing the compression by the disc. How about whether there is any spine fracture causing, or the bone fracture I should say, the vertebral body bone fracture causing retropulsion and then causing compression to the anterior part of the cord. That means your pain and temperature, spinal thalamic tract, or whatever, and that will cause a symptom or the sign. And the second thing is, how about if we know this is the cord cross section, we have the blood supply inside the cord, and mainly the I should say anterior blood supply and the posterior blood supply of the cord. And the problem is, okay, whenever we distract or compress, we will also jeopardize or interrupt the blood supply or block the supplying anterior spinal artery or posterior spinal arteries continuity, and then they will also cause either free hemorrhage there and then eventually infarct of the cord, whether it is anterior part of the cord being infarcted or whether it's the posterior part of the cord being infarcted. It depends. So in mechanical terms, it is the simplest term because the disc is more easily to protrude than the bone, unless the bone is fractured. So the flexion and extension mechanism can help everyone to make a diagnosis. But in more real-life situation or complex terms, there could be the bone also being injured or fractured. There could also be a jeopardized blood supply and causing the problem.
Very good. One follow-up question is that, like, according to you what just said, it seems like the hyperflexion would tend to more likely to lead to the anterior cord syndrome then, right? Relatively, according to your observation.
From our observation and experience like that,
right.
yes.
Would it be the other way? That's one thing is someone actually also talk about is whether the extreme extension would also lead to the more some of the cases with the anterior cord syndrome because of overstretch of the anterior cord. Is that possible as well?
It is possible, but remember, if it is a stretching of the anterior cord, it will causing the edema of the cord. That means internally it could be a micro hemorrhage or whatever. But usually the soft tissue will have its elasticity. That means a stretching of it, it will have edema, and then eventually the edema will subside. And it all depends on whether it's a peripheral nerve fiber or not, or the neuron or the axons, whether it can get a repair or not. If it can't, it will be becoming myelomalacia. Okay, that is the eventual sequelae of it. But the crushing usually is the crushing that is also causing the problem. So that will be a crushing or extrinsic compression causing a problem, or distraction and also intrinsically hemorrhage and edema that also cause a problem. That's all possible. Yes.
So the spinal cord is not necessarily can be injured due to the PID, but could be due to the traction injury, and that causing local edema and hemorrhage over the posterior side of the spinal cord.
Yes, of
It
course.
doesn't mean that, like, okay. So I think this is a quite important clue to the PT and OT students that when you treat a spinal cord injury case or treat any case with spinal injury, make sure that you know about the mechanism of the injury of your patient. This could help you to understand what kind of this injury, and when you provide training, physical assessment, physical training, or in OT maybe activity or posture or wheelchair fitting, those kind of thing, you have this in your mind. What happened? What mechanism that happened for this spinal cord injury consequence or the impingement to the spinal tissue, or whether that's due to flexion or extension. You know the mechanism. You can avoid re-injured your case during your assessment and during your treatment process, and you can monitor the change with the understanding of this mechanism. You can have the expectation that if that is extension injury, you expect that it's due to traction, so it's nothing related to the IV disc. So when you check about the progression of your patient, not just check about the IV disc all the time. On the other hand, if you know that's a kind of flexion injury, then you need to check about is there any change of the disc in relation to the spinal canal, and that will help you to monitor the change of your patient all along in your rehab treatment. I think that's quite important. Now, because time is running short, and we have one more question about torticollis, and I would rather to pass it to Sienna to answer that as before, which is more accurate for you. Is there any other question that we have so far? So we don't have further question from you, and I would like to raise a question to Dr. White, and it should be the last most important question that I have mentioned in the class. And maybe if you don't have time, the rest of you can go to check on the discussion forum later. Now, it's about the interpretation of a very common line for the whiplash injury, the Rackham Cephas baseline, and it's one of the line that is quite important for upper cervical injury, like for whiplash. When it's very common, we check it. So can you help us to read it adequately, carefully on CT or on X-ray?
Okay. Do you have a sample CT or X-ray graph?
It's not on here.
Okay. Let me check whether you have a superimposed line in your probably that is all right.
Yeah. So but because we haven't got in the lecture, it was a bit too long.
Okay.
So we haven't talked about it in very detail.
Make it very short because they said it is 2 minutes left. Okay. The line is helpful on CT or X-ray, but there is we also need to measure the several distances. Okay, of several lines. We usually make a cross, and making sure the cross, we measure the Bayesian distance and also the anterior-posterior distance. I think the most important thing you have to know is the anterior-posterior gap between the odontoid process and the C1 arch posterior bony cortex. That is important. That means, okay, not to have a hardcore data on all these numbers. Remember, if it's widened, particularly in the flexion view, making sure it is not a pediatric patient, because pediatric patient, they will have very flexible soft tissue. That is all right. But if it is an adult, it's widened on flexion, suspecting atlanto axial antero-posterior dislocation. And then when you have an open mouth view, making sure you have the Chinese character mountain, the Chinese character shape. If the lateral masses of the C1 vertebra, there is a distance between the C1 vertebra and the odontoid process. On both sides, they should be of equal distance. That means the two radiolucent or dark lines should be normal in width.
Which two lines?
We call that the equal distance between the lateral mass and the central odontoid process. On both sides should be equal. If one side it is deviated from the other, that means one side, the odontoid process, is closer to one lateral mass and further away from the other side or contralateral lateral mass. So we are suspecting rotational subluxation. That is more important, I should say.
So they need to check. This. So they need to check the distance between the odontoid process and the distance
and the C1 arch posterior border. Okay, and the second thing is to check whether there is any equal distance between lateral masses and odontoid process on frontal open mouth view. That means the X-ray beam shooting right at the mouth when the mouth is opened. And if you look at, do you have the
this is the natural looks.
lecture notes? It could be page 2 or
That's an open mouth view.
Yeah,
For your spine 1 lecture.
and you can see there is you can see the two arrows there. They are of equal distance from the lateral mass. If it is, this is the lateral mass. If the this is the odontoid process. If the lateral mass is moving closer, that means the other lateral mass is being deviated. So it is a rotated scenario or rotated scenario, and this one will be rotated and causing this lateral mass to be closer and this lateral mass to be moving further away from the odontoid process. That is important. So all you need to know is having a concept whether it is anterior or posteriorly dislocated or subluxed or rotationally subluxed, and that is more important.
Yeah, I think that gives you additional information So if any of you still have any further question about imaging, you also welcome to post it on the discussion forum within these 2 days, and we will invite Dr. White to provide additional explanation for you to understand. As I have mentioned in class, for PT student, your examination will include some questions, no matter MCQ or in your long question, that we will cover something about the basic interpretation of the X-ray and CT scan and MRI, and you need to have the basic understanding about how to interpret that. And I think those things that we cover in the lecture notes actually will be enough for you, and we today have Dr. White to give you supplementary advice how to correctly interpret the imaging films for your understanding. And see, now we have very last time for Sam. If you have any additional thing you would like to tell
No, I
them.
think the quick response is I saw Katie actually responds the question I asked her some time ago. I think the reason I don't think we have time to elaborate, but I think what her reasoning is actually is one way to explain why the straight leg raise is actually not is not induced, because the impingement is actually from the posterior part of the cord. So and straight leg raise can actually somehow alleviate the stenosis problem. But this is only a speculation, but it's a good thinking. Yeah.
Good.
And one final announcement for the OT group is I would post some of the sample question on the blackboard later, so that you know the format of the test to be held on Tuesday. Okay, so prepare the test well.
And for the PD students, make sure that you have checked it. We have got the day for examination. Check it on the blackboard for the update announcement about the arrangement for your examination in December in this month. And also we have got some sample questions on the blackboard already. Please have a look. And although the questions are not exactly the same, but the format will be about the same when you go to the examination. And you can also find out the past paper in the library for the long answered questions. We have also put it in the library in the archive. And if you have any question, you can ask the librarian to assist you to find out those past papers that we have uploaded on the library for your revision purpose. Still, have a look at it. So get into the rhythm during your revision time. And thank you very much for Dr. White today to give us some professional understanding about how to interpret the imaging reports and to how to correctly understand about the pathology. And also thank you for Sam to come over to elaborate something for the OT students, and PT students can learn something as well. I hope you enjoy the session. And for the rest of the questions that we will pass it to Sienna, and please be reminded to check it on your blackboard on the discussion forum, and Sienna will answer you in further detail, and which would be helpful for your revision as well. Now,
they can still post some questions.
We
right,
still
in
open the
time.
discussion forum for you.
We try to respond to your answer.
And we will respond to your questions. And also please make use of the discussion forum before your examination. Will be a very good platform for you to ask questions and for your revision.
Okay, wish you luck to all of your examinations, graduation, future career, and practice.
Thank you, Dr. White, and thank you, Sam. And we'll see you later. Good luck, students.
Okay, see you.